We move to the next presentation. Yves Panis from Beaujon in Paris, France, will discuss a very interesting topic, but because he will address the problem what remains unclear in 2011 about laparoscopic colorectal surgery. Could we move this here? No, I see. I ask maybe Felice Borghi to take over the chairmanship. Thank you.
Excuse me. Yes, okay. Thank you very much, Mario, for this invitation. It's a difficult topic because it's a very short presentation. I will try to show you some results in laparoscopic surgery. So what we all know today is that there is a lot of randomized study and meta-analysis, and the first result is that, and you know, which is clear, is that we get exactly the same oncological results with laparoscopy and open surgery in colorectal cancer. And here you have the meta-analysis of the most important studies on the topic. The second result is concerning rectal cancer surgery. Here you have the result of the classic trial with one good result with rectal cancer, same recurrence rates, same long-term survival, and quite a bad result concerning the operative result with a very high rate of conversion, 34%, increased rate of sexual problem, increased mortality rates if you make a conversion of a laparoscopy during rectal resection. It's the results of the classic trial. It was the first randomized study on real rectal cancer patients. And finally, more R1 resection, 12% versus 6% if you do by laparoscopic surgery. So what we can say with this first study is that it's not very good to do by laparoscopy. But anyway, the current knowledge on this topic is that we have to do colonic cancer by laparoscopy because of the same result and probably better postoperative results. And which remain unclear maybe is the impact on mortality, the long-term benefits, the problem of T4 tumors, and maybe the problem of low rectal cancer. Very briefly, there is last year a large publication from the Korean trial published in Lancet Oncology, which tried with a big experience. It's a second randomized study on rectal cancer. And this study clearly demonstrates in an expert center that we can get very good results of laparoscopy for rectal cancer patients with a very low rate of conversion, very good oncologic result on the specimen, and better operative results. So this second study probably validates in most of the centers the laparoscopic approach for rectal cancer. Concerning the T4 tumors, there is no data. We only published last year one of the first study concerning the use of laparoscopy in T4 cancer patients. In most of the study, it's a contraindication. It's a strong contraindication to do laparoscopy for T4 cancer. In fact, we do 39 patients, and I just want to show you briefly this result, is that we have 87% of R0 resection, which is exactly the same rate of R0 resection than open surgery. So the idea is not to say that today we can do easily the T4 tumor with laparoscopy, but probably in expert center there is more and more a place for this kind of tumor by laparoscopy. Finally, the long-term results of laparoscopy for colorectal cancer. Here you have two different studies and two different results. If you look at the long-term result of the classic trial, there is no difference, 3% versus 2.5% concerning intestinal obstruction, and there is no difference concerning incisional hernia, 9% versus 8%. So probably in this randomized study with the 3 years follow-up, it's not a big follow-up, no benefit, no long-term benefit of laparoscopy. On the opposite, if you look at the experience of Éric Rullier in Bordeaux, it's only rectal cancer patients. And what you observe is a clear benefit of laparoscopic approach for the wound protection, and you reduce the rate of incisional hernia. So controversial result, and today we cannot say that if you use laparoscopy, you reduce the rate of adhesion or you reduce the rate of hernia. Nobody knows, in fact, because there is no clear randomized study. Finally, I just want to show you concerning the mortality rate, what we get, the results that we get in France with a very large number of patients, 84,000 patients, and we observe a clear reduction of mortality rate if you use a laparoscopic approach for colorectal cancer. It was never demonstrated in randomized study. You go from 5% to 2%. But the most important bias is that maybe there is selection of the patient. In fact, there is no selection, because if you take patient without any comorbidities, the easiest patient, again, from 50 years old to 79 years old, you reduce significantly the rate of mortality. And similarly, if you take patients with at least one comorbidity, you get exactly the same result from 60 years old to 99 years old. So it means that it seems that there is proof that laparoscopy also reduces the rate of mortality in colorectal cancer patients. Another clear result is concerning the laparoscopic approach for diverticulitis. Here's the only one randomized study on this topic published 2 years ago, which clearly demonstrates the benefit in the postoperative period of the laparoscopic approach. And today, all the surgeons agree that we have to do this elective operation by the laparoscopic approach. Concerning the IBD patient, here you have the meta-analysis in Crohn's disease with clear benefit of the laparoscopic approach for Crohn's disease. Here you have a shorter hospital stay. You get a shorter return to bowel function and normal oral intake in this meta-analysis. And most importantly, you get a significant reduction of postoperative morbidity if you use laparoscopic approach for Crohn's disease, from 20% of morbidity, and it goes to 12%. So today, again, strong evidence that we have to use laparoscopic approach for all the patients, selected patients with stenosis in Crohn's disease. So conclusion for IBD, current knowledge, we have to do this operation by laparoscopy for both ileocecal Crohn's disease with stenosis and for subtotal colectomy. I have not time to show you the result, but it's exactly the same result, better postoperative result, and same long-term result. What remains unclear? Maybe in complicated Crohn's disease, is it a good approach? And in ileal put channel anastomosis. Briefly, we published 2 years ago our experience with only complicated Crohn's disease, 54 patients, and we compare with 70 patients with stenosis, so the easiest case for laparoscopic approach. And what we observe in this study, when I am talking about complicated case, it's recurrence, abscess, and fistula. We have exactly the same morbidity rate. So one of the first paper which seems to demonstrate that in experienced hands we can do complicated cases also by laparoscopic approach in Crohn's disease. Concerning ileal put channel anastomosis, here you have all the largest series to date, and we published in 2 years ago. And again, it's a benign disease. It's only a problem of technique. All the biggest series clearly demonstrate there is no randomized study, or only one small randomized study, but there is no big randomized study, clearly demonstrate the benefit of the laparoscopic approach for ulcerative colitis and to the realization of ileal put channel anastomosis with very good postoperative results. So today we have to do probably this operation. If you have the experience in open surgery, you have to do in laparoscopic approach. And there is recently a paper published in Surgical Endoscopy which seems to demonstrate that if you do this operation by laparoscopy, maybe you reduce the rate of adhesion. And you know that it's very important in female because one of the drawbacks of this operation is the reduction of fertility if you do ileal putsch anastomosis. In this study, they observed that the patient with abdominal wall adhesion is clearly reduced in patients with laparoscopy if you compare with open control or even open with treatment of adhesion. So I have finished for laparoscopy. I just want to show you in few slides what is maybe the future of this approach. First is the natural orifice transluminal endoscopic surgery, node surgery. You know that we talk about nodes for many years, but very few studies. Here it's a publication last year in Annals of Surgery of 500 patients operated by nodes. And when I saw this paper, I say, we have a lot of results with node surgery. In fact, not a lot. If you look at this database with more than 500 patients, you see that there is a lot of gallbladder surgery, 85% of the patients. Only 14 patients underwent colonic resection by nodes. And if you look at what is notes for this series, here is 14 cases. It's notes, but it's with 3 trocar added during the operation. So it's hybrid operation. It's not really node surgery. So today we cannot say that nodes can be used in clinical practice in colorectal surgery, and no clear benefits and very, very few patients. Here, the same debate concerning robotic surgery. We all know that it's a very beautiful operation. It's very interesting to do this operation by robot. But the main problem is that today there is no benefit to use the robots in rectal cancer surgery. No randomized study. And all the comparative studies demonstrate exactly the same result. The same result, except one big drawback is the costs. And today, I don't know in other countries, but in France, it's completely impossible to use the robots if it's only for colorectal surgery, because it's very, very expensive. So if you have no benefit and it's very expensive, we don't use, because we have no choice. Finally, maybe the future, I'm not sure, is a single incision laparoscopic colorectal surgery. Here, 1 year ago, we published 13 cases, one of the first preliminary experience on this topic. More recently, Delaney group in Cleveland published the first case control study. There is no randomized study, a case control study of 29 patients in each group, which seems to demonstrate that there is no difference in terms of postoperative morbidity, length of stay, between the classic laparoscopic approach and the one trocar approach. Here we do exactly the same study, a case control study of 25 cases versus 50 cases by laparoscopy. We do a different operation from the right to the left. And what we observe in this study is that we observe a shorter, it's not a randomized study, it's only a case control study. We observe a shorter operative time in one trocar, probably because it is the senior surgeon who does the one trocar, so it's not a clear benefit. And what we observe also is a reduction of hospital stay from 1 day. So if we are honest, we can say that we get probably the same results between laparoscopic approach and single port surgery. But we do, with Léon Maggiori, we do a meta-analysis of all the comparative studies published to date on this topic. There is only 7 comparative studies on one trocar surgery. And when we observe with this kind of meta-analysis is that we observe a significant reduction of hospital stay and exactly the same postoperative morbidity if you use one trocar surgery. So in conclusion, what we can say is that laparoscopy today is clearly the best option for colorectal disease. For colorectal cancer, we have to use it. There is only 2 problems remaining, maybe. It's the problem of T4 tumors and the problem of low rectal cancer, because there is only 2 randomized studies. But there is no discussion for diverticulitis and all IBD patients. Concerning nodes, I think that we are waiting for comparative study. And we talk for many years of nodes, but we have no study. So probably there is a problem with this approach. For robot, I think that we are waiting for money because it's much more expensive. We cannot use today because of the problem of money. And concerning one trocar surgery, there is promising result, but there is no randomized study. Probably there is a small benefit, but we have to demonstrate that this benefit exists. Thank you very much for your attention.
Thank you, Professor Panis, with your analysis of literature, also with your big experience. You clarified all the controversies. Are there any questions from the audience? Question, please.
I'd like to ask you a quick question. Don't you think that, with your experience doing consumer result in a multi-center randomized trial for rectal cancer, that is a surgery that is strictly related to the surgeons and quality of surgery itself, is a little bit dangerous, especially if you do a study that is intention to treat, so you put all the conversion patient in the same group of laparoscopy, you will end up to have, to not see really good difference between open and laparoscopic surgery, and then when you see the series of single surgeons that have experience, that you will see the difference.
I think that in the classic trial, the first published, you get the real life results. It means a very high rate of conversion, very bad result, because it was not expert centers. I think there is too many centers with very few operations. If you take the Korean trial, you get probably the real result today in 2011. And I think that I completely agree with you. I think that rectal cancer surgery, whatever the approach, must be performed in expert centers. And if you have an expert center with experience in laparoscopy, you will get exactly the same results as the Korean trial, I think.
Just a comment. In fact, it's not a question, but from his question to your data, I think it's important to stress the data that you have presented also at ESA. I think you will publish on the French study showing this reduction in mortality, because this is really an everyday life and every surgeon data, and so it's really a very strong data comparing to what is in the literature at present.
Thank you. It will be published in Annals of Surgery in a few months.
Other questions? No. Binda? Please.
I would like to stress another point about Crohn's disease. Another indication is to save what I call the abdominal patrimony in people that need to have a great risk to have multiple operation and sometimes an ostomy somewhere. So best indication for Crohn's disease to save the abdominal
Yes.
and adhesion also are the patient at the greater risk to have other operation.
Yes, and I agree with you. And in our mind, what we changed for 15 years ago, I only operate the easy cases without any previous operation. Today, we operate all the Crohn's disease, even with 2, 3, or 4 previous operations. I think that we have to protect the abdominal wall. I completely agree with you, yes.
Another question?
Nicola from Parma. I enjoy a lot your lecture. I will ask you if you have experience about FAP, laparoscopy surgery.
Yes.
When you comment about this.
When I'm talking about ileal pouch and anastomosis, it was for both UC and FAP patients. So we do exactly the same operation for polyposis. So today, in young patients, if you have to do a total coloproctectomy, we do by laparoscopic approach. I think that we expect, it's not clearly demonstrated, but we expect 2 benefits. First, it's a wound protection. And second, it's a reduction of adhesion. And it's very important for adhesion because you know that in open surgery, approximately 10% of the patient will be reoperated by open approach. So if you can reduce the adhesion, it's very important. And most importantly, probably is for female patients, young female patients.
Do you have experience, is there is something in the literature, I don't know enough about that, about desmoid problem? Because in fat patient now it's difficult if you follow very well the die for cancer of the colon. But the big problem, forgot for papilla, whatever, is desmoid inflammation. So after, if you have adherence, you cannot go anymore get in, and you need a big small bowel resection. Maybe, I don't know, I have no experience. If the first surgery is laparoscopy, there is less irritative problem, and maybe desmoid is less problem. I don't know.
You mean if you do redo surgery in a patient who underwent previous laparoscopic surgery?
Yeah, I am saying because a big issues in fat patient is desmoid problem. I mean,
I don't know. I'm not sure that fat patient is the most difficult cases. I think the most difficult cases for me, after more than 1,600 patients operated by laparoscopy, the most difficult patient for me is Crohn's disease patients. We do the most easy operation, which is ileocecal resection, but it's the most difficult with a higher rate of conversion. Today, for ileal pouch anastomosis or rectal cancer, we have less than 3% of conversion. For Crohn's disease, after 15 years, we have 12% of conversions. So probably for me, it's the most difficult cases.
Thanks a lot.